Welcome to the Virtual Cardiology Congress sponsored by Johns Hopkins University School of Medicine on CardioCare Live. My name is Dr. Roger Blumenthal, and you are tuned in to a live session called Overcoming Disparities in the Management of Chronic Stable Angina. My close friend, Dr. Joanne Foody, is Associate Professor of Medicine at Harvard Medical School. She works nationally and internationally to prevent cardiac disease and to promote cardiac rehabilitation. Joanne has a particular focus on women and heart disease, and her research is focused on identifying and promoting strategies that prevent adverse cardiovascular events in people with and without coronary artery disease. Before we get started, I would like to remind our audience that we will be taking questions in real time throughout each presentation. You can send us your questions anytime during the program through the box in the lower left-hand side of your screen. Thank you very much, and Joanne, welcome to Baltimore.
Roger, thank you. It's really a pleasure to be here. And today I'd like to address some of the disparities that we see in the management of angina. And a lot of this is related to the new guidelines for stable ischemic heart disease that have just come out. So I think this is a really important topic. Now, I'd like to review some of the burden and significance of angina in various patient populations. And as you mentioned, I have a particular focus in women, the elderly, as well as certain ethnic populations. I'd like to review a bit about typical as well as atypical angina and presentation as well as pathophysiology and how that might inform our management, and then ultimately review some of the traditional as well as some of the novel management strategies that we can apply. So clearly, angina has been around a long time. I think, you know, as a history major, I enjoy the fact that that we've known for such a long time. Heberden's initial experience of angina, that really very typical sensation, clutching in the chest that we appreciate. So this has been an issue for centuries. And I think the issue now is, what do we have as far as an evidence base to improve outcomes for this very large group of individuals? Now, what people may not recognize, and I think as cardiologists sometimes we may think that we've cured all of angina, but in fact, AHA reports that there are almost 7 million Americans that suffer from angina pectoris, and that despite all our advances in cardiovascular medicine, that there are over 13 million episodes of angina a week in the U.S. And if you break that down into minutes, about 1,000 episodes of angina a minute. So it's a lot, and I think it's something that as cardiologists we may not even see these people. We think that a lot of them are being managed by internists, and patients themselves may not even recognize that what they're experiencing is angina. So we appreciate that there's a growing prevalence of angina, in large part due to our reductions in mortality. You know, we've been so successful extending life, reducing mortality, but we do have a fair amount of individuals living with angina. So treatment, not only for quantity of life, but quality of life, are really critical. And so a particular group of individuals that are certainly overburdened with angina are the elderly. And that, in fact, as people age, that the clinical effects and manifestations of CHD in our older patients really start to change. We unfortunately recognize that about 50% of elderly women and about 75% of elderly men have obstructive coronary disease at autopsy. So the burden is really significant, and that, you know, if we couple that with the fact that we have a growing number of older individuals in our society, we can see that we have a dramatic number of individuals who have obstructive CAD, stable ischemic heart disease, and angina. Now, as far as symptomatology, I think we always think of that historic description from Heberden. But the reality is that the clinical manifestation of typical angina is only about 40% of individuals. And there are other symptoms that people have that may not be fully characterized by a clinician or recognized by a patient. So one of these is dyspnea, particularly common and can be related to ischemia in a stiff, hypertrophied left ventricle. We tend to see this more in our African American patients. Issues of more nauseous feeling, vomiting, fatigue may be more common, for example, in women. And we tend to see a variety and a heterogeneity of symptoms that often is difficult for both the clinician and the patient to recognize. One of the big factors is that as individuals age, they tend to think that a lot of the symptoms may be related to age, and that they're slowing down, they may be more sedentary, and in fact may not experience angina because they're just not moving at a rate or rapidity that would allow them to experience it.
Joanne, one of the questions that's come in mentions the fact that perhaps it's not so much women are that much different than men, but rather it's being older, that older men may have more of these atypical symptoms, such as the women who, on average, are present 10 years later. Is that a fair statement, or are women wired differently in terms of angina?
I think it's a little bit of both.
Okay.
I think that some of it is an age-gender interaction such that women are older when they tend to present, are more likely to have perhaps smaller vessels, though, from a coronary anatomy perspective, but I think that the unique aspects of angina in women tend to be more related to that perimenopausal, immediately postmenopausal period. I think that's a unique time frame for women, but I think you're absolutely right. In older women that we tend to see, I think their constellation of symptoms are much more consistent with what we would see in older men.
Okay.
So, perfect segue into this, that if we look at CAD by gender and ethnicity, that these data show percent with significant CAD by race, ethnicity, and then categorized by male or female. And what you can see is that in individuals that have stable chest pain, we may be less likely in our African American, both men and women, to demonstrate significant obstructive CAD, whereas we tend to see more in, if you will, North American or Asian communities with obstructive CAD. So there is some variation. In general, across the range of race and ethnicity, women have less obstructive CAD for any given chest pain syndrome. And that has been demonstrated, as you can see here, across multiple populations. So I think this is a challenge for all of us who care for women in particular, but does speak to some of the anatomic differences that may exist.
And is this because there's more endothelial dysfunction, that if you have, say, a 30 to 50% narrowing, women may be more likely to have some paradoxical vasoconstriction or constriction of the microcirculation?
Well, I think that the microcirculation is really key here. I think that, again, given size of arteries in women, as well as what I think tend to be more susceptibility to risk factors. So in some respects, women's arteries, as they go across their lifetime, tend to look more like a diabetic artery with more diffuse disease rather than focal stenoses. Now, whether that's the impact of estrogen, hormone modulation, I think we need to have a lot more research in this area. And unfortunately, the majority of clinical trials that we've had in acute coronary syndromes and ischemic heart disease have been done in men. So I think there's still a lot we don't know. A lot of this is conjecture, but we recognize that, at least from an epidemiologic perspective and from an observational perspective, that there's significant differences in how this plays out from obstructive coronary disease.
Okay, great.
So one of the big issues that we face, whether it's with women, whether it's with racial or ethnic minorities, is that despite everything we do in cardiology, there's significant disparities. There are differences in the way people are cared for. There are important differences in how one area of the country may care for a particular disease, and I think that we really need to look at how we can apply tools for addressing these disparities. Now, one of the nice groups that is addressing this is CREDO, which is a partnership of multiple organizations trying to approach this along with the American College of Cardiology to see whether we can reduce ethnic and racial disparities in cardiovascular care. And I think it's critical, again, that we recognize, given some of the differences we've seen by race, ethnicity, and gender, that we're faced with a growing diversity in the U.S. population, and it's estimated by 2050 that we'll really see a very remarkable shift in patients in the United States with far more Hispanics, Asians, African Americans making up a significant proportion of the population. So our ability to understand how something like stable ischemic heart disease, angina, works in those patient populations, as well as whether treatments can modify and improve outcomes in those populations, will be critical for improving the health of the whole country.
Sure. And do you think you and I will be retired by 2050?
I can only hope.
I can
only hope. So, you know, again, when we look at it, I think that the other thing is that there's striking regional variation in the change of population. So as all of us may be faced, you know, Roger, look at us in the Northeast, may have a very different demographic than what a cardiologist practicing in the South would have. So again, I think it's really important to look at the growing numbers in this particular instance of Hispanic or Latinos and trying to understand how best to not only understand disease but communicate.
Right, and I see, you know, there's SEC, Southeast Conference football schools, you know, there's some pretty big people down there, especially
Absolutely.
big linemen.
Absolutely.
The West is a little more finesse than the Pac-12, but
clearly, Big Ten though, Big Ten, we've got that.
Big Ten are some, you know, your son's at Michigan.
Absolutely. Now, I think, again, when we think of disparities, I think it goes without saying that we have groups in this country that do not achieve the same outcomes as other groups. And if we look, for example, in African Americans that unfortunately are most likely to suffer from chronic conditions or disability. And when it comes to angina, no different. You know, I think we continue to see these disparities, and you can see here dramatic proportion of chronic diseases, multiple comorbid conditions. And again, it fits into our whole mantra about modifying risk across the board. Now let's get back to angina. I think there are multiple classifications. And I think we talk usually about typical angina, and we recognize that substernal chest pressure, discomfort, there's a certain quality to it that's characteristic, often provoked by exertion or emotional stress and relieved by nitroglycerin or rest. What is difficult are those that are in this probable or atypical angina. Maybe you have two of the above characteristics, not all three, and then clearly there are also individuals that have non-cardiac chest pain. Anything from the skin on the front of the chest to the skin on the back, and virtually anything in between can cause chest pain. But I think I want to focus on both typical and atypical angina. And perhaps those aren't the right words. Okay. And perhaps I think we need to do a better job of describing, if you will, the continuum of ischemia and how it may relate in a given individual. I think we're all well aware that we always need to look at any test, any diagnosis based on a pre-test probability. And what we know is that in general, younger individuals are going to be less likely than older individuals to have angina. And you can see here, looking at non-anginal chest pain, atypical angina, and typical angina, you can see as individuals age, obviously the proportions of all go up. The issue, though, becomes when we look at things like typical angina, meeting all three of those classifications, and we see that women are much less likely proportionally at any given age to have those symptoms. Now, is that a real phenomena? Is that a burden of disease? Is that underdiagnosis? But what we do see, again, similarly across all the ranges, that women tend to have less presentations with any of these proportionally. Now, no one can read this, but I think what I want to highlight is that if we look across multiple angina cases, and in this particular analysis of nearly 200,000 women and 200,000 men from countries around the globe, they found that angina, in fact, was more prevalent among women. So women tended to report more angina, and that if we look at this, though, despite reporting more, we saw less utilization of evidence-based therapies. So there's a disconnect, and I think we're still trying to disentangle what the right rate of treatment is and also what the right rate of diagnosis is in women. we also know that women who present with symptoms that are suggestive of angina are much more likely than men to have normal coronary angiography. And I think that goes back to our discussion of potentially pathophysiologic differences, maybe endothelial dysfunction, but again, women are much less likely to have an abnormal, significant stenosis on coronary angiography.
So Dr. Weaver writes in that in these individuals who don't have an obstructive disease, he would presume that these are more likely to be women with risk factors where you might have endothelial dysfunction. Is that a fair statement?
So it's absolutely a fair statement. So I think that, you know, these women tend to be slightly older, have more risk factors, and what is really important is that it's not a benign prognosis. So with angina, and even in the presence of normal coronary arteries, these women still have worse outcomes. Okay. So maybe that's a factor of the endothelial dysfunction, the milieu, but again, problematic. So if we look at women and we look at the frequency of non-obstructive CAD in symptomatic patients, it's estimated that up to 20% of symptomatic patients presenting for coronary angiogram have no findings, at least of obstructive CAD. Okay. But there's a disparity that 60% of those are women, but only 40% are men. So women tend to are much more likely to have non-obstructive CAD. Now, one of the problems is that often patients are told, don't worry, you don't have coronary disease. And I think, Roger, both you and I as preventive cardiologists, we recognize that that really doesn't do our patients a service, and that traditionally these patients have just been told, you know, you're fine. When I think we recognize that prognosis is probably not as benign as has been previously thought, and that particularly for individuals that go on and continue to have persistent symptoms, or those that have frequent rehospitalizations, or those with multiple risk factors, I think this is a subgroup we really need to pay very careful attention to. And in fact, in data from Martha Galati, who did this really nice study looking at 5-year outcomes in women with symptoms on presentation, but no CAD by cath, what they found was that the annualized event rate over 5 years was fairly high, surprisingly so. So that even in the group that had clear arteries, about 13% over 5 years. Now, if you had more than a 50% stenosis, but were not 70%, again, as you might expect, 25%. So I think there's a continuum of disease. I think we have to recognize that the coronary angiogram certainly does not give us information on functional disease, and that we probably need to do a better job of further risk stratifying these individuals who have, if you will, no quote-unquote CAD.
Gotcha.
And, but if you further refine them based on ischemia, for example, so here's prognosis of women with ischemia and no obstructive CAD, that you can see that this is present in about 20% of women with angina, but again, no CAD by cath, and that the events are largely driven by hospitalization, but that you can see that individuals who have ischemia have much worse prognoses. So I think we need to take everything into account and try to sort out how best to manage these individuals. Further, if we start to look at the women that continue to have persistent chest pain, even in the presence of obstructive CAD, and remember that these are individuals classified with angina based on our definition, but still have a normal cath, that in fact their prognosis is really quite poor. So I think between ischemia, ongoing symptoms, we need to do a better job of managing these individuals, probably with anti-ischemics, but also disease-modifying agents, and then managing the risk factors that go along.
By the disease-modifying agents, you're referring to statin therapy, better blood pressure control?
Right. Okay. Absolutely. And I think it's twofold, right? We always want to apply the, if you will, the the therapies that improve outcomes and improve quantity of life, reduce events, but then there's the symptomatic issue of how we deal with quality of life as well. And so in angina, we really have to come full circle and deal with both those issues together.
Okay.
Now, so the concept is that women, as you've mentioned, have a lot more endothelial dysfunction, maybe microvascular dysfunction, and the data support that in studies that about 50% of women with chest pain and normal coronary arteries have subnormal coronary flow. When we look at flow velocity reserves or other functional assessments. The difficulty, though, is that traditional risk factors aren't necessarily accounting for all that risk. They account for some, but again, I think we don't have a great understanding of all the things that may drive it, whether it's hormones, other factors that mediate endothelial dysfunction in women. And we know that, as we mentioned, that this really isn't a benign condition, and that women that have chest pain despite normal coronary arteries can go on to have microvascular disease, endothelial dysfunction, which ultimately can translate into adverse outcomes. So some of this may be a phenomena looking at remodeling and how women may have a slightly different response. So some have posited that perhaps women's arteries are less able to remodel in a positive fashion for a similar burden of atherosclerosis. Again, I think these are all hypotheses. But again, I think we need to have a lot more research in our understanding of angina and ischemic heart disease in women. In this particular study, a small study looking at 100 women with chest pain without obstructive CAD on their angiography, they found that 70% had no, or at least less than 20% stenoses, and 30% had minimal. And so, again, it's difficult to really try to tease out how coronary atherosclerosis may ultimately impact women, but we're trying to understand it. But again,
Joanne, a few questions dealing with statins and women. Dr. Poland wrote in about if you have someone who you document coronary disease, say less than 50%, is it reasonable to give statin therapy to improve endothelial function? And what is your take about the position by some on the left coast that we shouldn't use statins in primary prevention?
Well, so, I think that I view cardiovascular risk and coronary atherosclerosis as a continuum. Okay. So as much as we are saying that these people have quote-unquote no CAD, virtually every single person that I've shown data here or in other studies have coronary atherosclerosis. They don't have obstructive CAD. Okay. So they have disease, so they have CAD, and each and every individual that has any atherosclerosis on their angiogram, whether stenotic, should have a statin. I think one of the issues is that it's not clear where we draw that line. We know that atherosclerotic risk is so pervasive. We know from your studies, whether it's coronary CT, coronary calcium scores, that we're not great at identifying subclinical atherosclerosis unless we really look, and that a lot more people have disease burden. So I am probably much more aggressive in primary prevention when it comes to statins. I think for those that say that statins don't work in primary prevention for women, I think that a large portion of that misconception is because we don't have sufficient number from single individual trials to answer the question, but that when we pool data and we include newer, larger trials that have looked at primary prevention, statins improve outcomes in at least intermediate risk primary prevention. And
Sami and Mara from your institution, I guess, did a nice meta-analysis on women incorporating the Jupiter results with AFCAPS and I believe MEGA, and and
Right.
showed a significant decrease
Right.
in events.
And I think so. I think the issue for all of us is, we see that there's a tremendous amount of risk burden. We see that it relates to disease, whether it's frank angina, microvascular disease. It is the atherosclerotic process, and I think we need to be much more aggressive. And what you'll see from the new guidelines is that they really take that stance, that it's a multifactorial approach. We're not just focused on the coronaries or the stenosis, but we're really looking at a global risk reduction for patients.
Very good. Thank you.
So again, I think when we look at this, there's multiple data, and I think that the key is that we have to get past this concept of normal coronary arteries and really help educate patients so that they understand that despite not having obstructive CAD, they have coronary atherosclerosis and need to have it addressed. Okay. This is particularly important in women. And you had mentioned the coronary microcirculation, and I think one of the issues is whether in fact there are differences, that women tend to have smaller vessels, a more reactive microcirculation, more hormonally mediated endothelial response or dysfunction, and maybe more susceptible. So I think we always have to think about the fact that the coronary bed exists predominantly in the microcirculation, although we focus so much of our work, effort, and interventions on the macrocirculation. But you can see from these images just how much volume and square footage the microcirculation has. Now, we talked a little bit about the pathophysiology of microvascular dysfunction, but really this is multi-pronged, right? So we have traditional risk factors that we know clearly mediate endothelial dysfunction. We have a variety of other factors, again, that work on the endothelium, but then we have a variety of factors that work on smooth muscle cell dysfunction. And so there's impaired vasodilation, impaired vasoconstriction, and coupled together, they really relate to microvascular dysfunction. So when we look at something like this, then it would make sense, at least intuitively, although it hasn't necessarily been tested in trials, that you'd want to develop a series of interventions that would address both sides that are driving those two separate areas. And I think talking as preventive cardiologists, I think we all recognize that in our current society that far too many people have comorbid illnesses, and that if we look at the multiple risk factors that patients have, we're now looking at a diabetes epidemic, 1 in 3 individuals with diabetes. We have multiple other factors that may impact our ability to care for individuals, COPD, for example, and beta blockers, and trying to really help manage these individuals. Peripheral vascular disease and congestive heart failure are really very common in our patients. So we really have a very challenging population, and all of these factors really come together to increase risk. And so I think given all the risk factors, we appreciate that endothelial dysfunction is likely to be common in both men and women. And I think that, people may not appreciate that, in fact, the function or dysfunction of the endothelium actually predicts outcomes. And so in this particular small study from the WISE study, looking at women with no or only minimal CAD who had QCA and Dopplers, that in fact endothelial dysfunction was a predictor of poor outcomes. So again, getting back to the point, I think none of this is benign and needs to be treated aggressively. And these are the major adverse cardiovascular events that are associated with endothelial dysfunction, and again, pretty consistently you can see that across a wide variety of studies that there are poor outcomes associated with it. There are other ways to look at this, so we can look at microvascular reactivity, again similarly in the WISE study looking at intracoronary coronary flow reserve, similar results showing poor outcomes. Now I think, there are a lot of ways that people can have angina. Obviously there's the traditional, more typical angina that isn't microvascular, is macrovascular. And I think when we think about how to manage these patients, we obviously want to apply the evidence base. we want to apply revascularization strategies in appropriate individuals, but even with the best interventional strategies, whether it be revascularization with cabbage or with PCI, we still have some individuals who have persistent angina despite therapy. And so, in fact, there are a whole host of agents that we use, beta blockers, calcium channel blockers, nitrates, but still we have patients who can report as many as 2 to 3 angina attacks per week. And those are really our kind of non-responders. And I think the issue is how to develop further therapies, apply other interventions to improve their outcomes and their quality of life. So it becomes really challenging when you have individuals that are on multiple medications, right? We've already mentioned multiple therapies, statins, ACE inhibitors in some, likely beta blockers, and then a cocktail of drugs to manage angina. Often we're up against the wall trying to manage their symptoms.
Sure.
And one of the things I think that may be not appreciated is that even after PCI, as good as we think these interventions are, this was an interesting study from the NHLBI Dynamic Registry looking at symptom relief and angina at 1 year. And the overall prevalence was 1 in 4 individuals still had persistent angina at a year. And I think we don't always think about that. I think that maybe we think we're a bit more successful. But a lot of people are living with angina. If you actually ask them questions, they will report angina, whether it be shortness of breath or some anginal equivalent. So I think it's important to constantly reassess this each and every time we see our patients. And again, in this particular study, that looking at 1 year after what was termed optimal revascularization by stenting or either surgery for relief of ischemia. So this was not done for survival benefit, not in post-MI. This was just for ischemia. That in this particular study, at 1 year, 60 to 80% were still taking anti-anginal medications, and 10 to 20% were still having angina. So it's a big issue. And further, I think that when people do have angina, it really impacts their quality of life. So this particular study looking at quality of life as indicated by the SF-36, looked at physical functioning, pain, vitality, general health, and what you can see is that across the board, compared with a normal U.S. population, that angina patients are much lower in their quality of life. So again, challenging all of us how to address the quality side of life for the significant number of individuals with angina. We also know that angina frequency correlates with depression, so really dramatically. So again, more impetus for us to treat it. Now I think we talk about outcomes in angina, and I mentioned quantity of life and quality of life, and I think we need to bring these together to really help best manage our patients with stable ischemic heart disease. So I think, when we think about angina, it really continues in many patients despite our best therapies, and that the burden can really deprive many individuals across many different groups, particularly the elderly, particularly ethnic and racial minorities, and particularly women. And I think we need to do a better job of identifying those individuals, providing evidence-based therapies, and managing them. And the economic and social burden of angina is really quite dramatic. And so I think this is really a critical topic for us as cardiologists, but also for the many internists who care for these patients.
One question from Dr. Red, from outside of San Francisco, wondered when, if ever, should you do stenting because it doesn't decrease mortality. How do you decide when to send a person for revascularization?
So they're obviously in the acute coronary syndrome. Those individuals receive percutaneous coronary interventions to improve outcomes, reduce death, MI in that group. When we talk about angina, though, and we assume that people have have been assessed, risk stratified, that coronary intervention dramatically improves angina and is an excellent first-line therapy for individuals who have high-risk features, who have certainly quality of life is being impacted. So it's critical that we know the anatomy and ensure that we've addressed stenoses that are greater than 70% or hemodynamic stenoses.
Very good. Thank you.
So, so I think, again, as clinicians, we really need to focus on a variety of issues in angina. We think about the more standard therapies, beta blockers, nitrates, use of agents such as ranolazine is newer to help improve quality of life. There are obviously other things that are important that we need to address with quality of life and really help the patient with angina achieve a full improvement in their quality of life. And so, this shows sort of where we've been with anginal therapies, and I think, over the last 100 years or so, starting with nitrates, moving through to beta blockers, and then introduction of coronary artery bypass grafting, calcium channel blockers, and PCI, and then finally one of our newest therapies is ranolazine. But it's been many, many years of using the same therapies. And only recently do we have a new agent like ranolazine that is now available to help our patients with angina. And I just want to wrap up in recognizing that the new 2012 guidelines are now out for stable ischemic heart disease. And one of the nice things about this is that it really takes a patient-centered approach. It brought together multiple groups of individuals, not just cardiologists, but internists as well, to really help address the challenge of stable ischemic heart disease and angina. And so if we think about it, we really have to consider that patients with stable ischemic heart disease and angina exist across our entire healthcare system, and that these guidelines challenge all of us to use what we're calling guideline-directed medical therapy. And this isn't just about addressing the stenosis. This is the global risk factor modification that needs to occur, as we talked about, for modifying disease.
So the ABC approach that's
ABCs.
in the textbook that you and I
Absolutely. So I think that as much as the guidelines didn't promote the ABCs, it's in there, and I think they strongly reference the 2011 secondary prevention guidelines, which really take that approach. I think we have national efforts, Million Hearts, a variety of others, that are really pushing those ABCs. And so I think that really forms the cornerstone for how we manage all these patients once they've been adequately revascularized, to the best of our ability, based on the evidence base.
Okay.
So I think now we have new guidelines that are much more aggressive in overall disease management for patients, that particularly those with stable ischemic heart disease, and that chronic angina accounts for a very significant burden in our population. We know that there's both typical and atypical angina, but that atypical angina is not benign. We tend to see that more in women, and I think we need to have more studies looking at how best to manage it. But I think music to our ears, Roger, is that traditional risk factor modification is critical and forms the backbone of management long-term for quantity of life. And then we really need to look at anti-anginals as far as quality of life and ensuring that ischemia is not impacting quality of life in our patients. That's
great. Dr. Berg from Queens wanted to get your opinion on hormone therapy. And if indeed some recent data, I believe maybe from the KEEP study, using, was it transdermal estrogen?
Low dose.
Potentially that is not harmful and may have some modest benefits. So maybe you could update us with your thoughts.
Sure, absolutely. So what we do know is that hormone replacement therapy is not a cardiovascular intervention in older postmenopausal women. The KEEP study asked an important question, or is asking an important question, as to whether or not earlier estrogen intervention in perimenopausal women may ultimately impact in a positive way cardiovascular outcomes. There's a suggestion, and the data are continually being read out, there were just data today, suggesting that early estrogen as true hormone replacement therapy in perimenopausal women continued over 4 to 5 years may actually improve cardiovascular endpoints. Now, this may be particularly relevant in those women we discussed with microvascular disease that tends to be particularly problematic in the perimenopausal years. So I think the jury's still out. The current guidelines for hormone replacement therapy suggest that women should only be placed on it for symptoms of menopause, not for symptoms of cardiovascular, and it should be of shortest duration. But there have been instances where I have managed women with very profound menopausal symptoms that was in fact chest pain with improvement in estrogen, although it's not currently evidence-based and it's not guideline-based.
Dr. Erica Topal writes in and wonders what your thoughts are about combination lipid-lowering therapy, and whether or not you think that rather than just giving a moderate to high dose of a statin, if you lowered triglycerides, would you be more apt to improve endothelial function, potentially angina?
Well, you know, right now our best therapy is moderate to high dose statins, and so my philosophy is to push the statins to a maximally tolerated dose and then address issues like triglycerides, HDL, or non-HDL targets secondarily.
Okay.
So I don't assign or live by trying to address non-HDL or triglycerides before the LDL, and certainly don't limit my statin therapy to do that.
Dr. Stefan Nissen writes in about use of ACE inhibitors and ARBs in individuals who have normal blood pressure. Can that also improve endothelial function, or are there certain other classes of antihypertensives besides beta blockers that might be helpful in this group?
So a variety of antihypertensives all improve endothelial dysfunction. So in experimental models, we're likely to see improvements. The issue is that we don't have any data to suggest that by applying them in individuals without hypertension that they may improve endothelial dysfunction. The two classes of drugs that are antihypertensives that we use in angina are beta blockers and calcium channel blockers. But again, other than those, we're not looking at ACE inhibitors or ARBs just yet in normotensive individuals.
Dr. Paula Johnson writes in, wonders what risk assessment algorithm do you prefer? Do you prefer the ATP3 algorithm looking at fatal and non-fatal MI? Do you prefer what was in the women's guidelines about total CVD, MI, stroke, heart failure, and PAD? Or do you prefer the Reynolds risk score, and what advice would you have for people?
Well, you know, I think that risk scores are most helpful for me in individuals in primary prevention. I think obviously, and the big issue in those patients is trying to motivate behavior change and help them understand. So as much as all these guidelines and risk scores are useful, I tend to like a lifetime risk score because I think it helps not only myself as a provider, but the patient capture their full risk and then empower behaviors that are often difficult for them to do. But it's certainly much more motivational for a 30-year-old to have a 20 or 30-year horizon or lifetime horizon to understand their true risk of heart disease, because those 10-year windows, whether they incorporate CHD, heart failure, whether they incorporate other metabolic risk, I think still underestimate a risk for a given individual.
And finally, Dr. Denard Robinson from Ann Arbor writes in also about in terms of emerging risk factors, what advice do you have about blood-based biomarkers? Do you measure those routinely in these patients with atypical chest pain? And do you ever do carotid intermedial thickness in women?
So as far as blood-based markers in individuals with angina, tend not to use it. Where I do tend to use them is in individuals who are in intermediate risk, where it may help me move to a more aggressive therapy. Also, similarly, I might use imaging in that same vein. So again, taking individuals perhaps with a very strong family history of premature heart disease, or a particular, let's say, preference not to be on a statin when perhaps I think they have enough risk factors to help use those either imaging or biomarkers as a tiebreaker to help move therapy a little bit more aggressively.
One last comment from Professor Brady Hoke, also from Ann Arbor, and he wanted to congratulate you on all the great work you've done on CardioSmart. He was hoping you could tell the audience a little bit more about what's available now for clinicians to be able to give patients.
Absolutely. So CardioSmart is the ACC's patient website for helping empower patients to improve outcomes for heart disease. And we're really very excited about it. It has a lot of tools that can help practice, a lot of tools to help providers. It has information on multiple cardiovascular conditions in both English and Spanish. They'll help improve outcomes. So for example, when it comes to angina, there's an entire community of patients that come together to have information and content about angina, tools to improve their health, as well as blogs and community chats to help support each other with angina.
Well, that's great. Well, Joanne, that was a fabulous talk, and congratulations on all the great work that you've done. I wanted to thank Abbott, Amarin, Boehringer Ingelheim, Daiichi Sankyo, Lilly, St. Jude Medical, University of Michigan Athletic Department, for their support of this important educational series. And please remember to complete the quiz at the end of the session to secure your CME credits, and stay tuned. My name is Dr. Roger Blumenthal, here with my close friend, Dr. Joanne Foody. Thank you very much for joining us here at Cardio Care Live, and we look forward to seeing you again soon.